Bismillah ar-Rahman ar-Rahim. I'm Dr. Iyad Rubi again with you. Today we'll speak or talk around or about one very important topic in urology, the neurogenic bladder. The urinary bladder is probably the only visceral smooth muscle organ that is under complete voluntary control from the cerebral cortex. Maybe it will come for you as strange informations, but I will show you later on how it will happen. Actually, normal bladder function requires coordination between somatic and autonomic nervous system, autonomic, sympathetic and parasympathetic part of this autonomic nervous system. Also, I will show you how later on. As I mentioned, it is under control or somatic autonomic nervous system participating in controlling this storage and voiding processes. For this reason, any nervous or neurologic problem can cause bladder dysfunction. And this is exactly the definition of neurogenic bladder. Any neurologic disease can affect negatively the bladder function, that meaning will cause neurogenic bladder. There is some examples quickly for this neurologic diseases: multiple sclerosis, spinal cord injuries, CVAs, Parkinson, diabetes, meningomyelocele, amyotrophic lateral sclerosis, sacral root or pelvic plexus injuries during pelvic surgeries, disc prolapses, hysterectomies or abdominal resection. Also, this is included in the pelvic surgery, and sometimes degenerative changes of the bladder muscle or nerve endings by aging or inflammation can cause these issues, these dysfunctions. As I mentioned you in different places or different lectures, what we have in the bladder, we have the trusor muscles, smooth muscle. This is very elastic, that usually this bladder will accommodate high volumes of urine without increasing or any increase in the pressure inside the bladder. It will keep the pressure inside the bladder near to zero. By why? How? By expanding, because it is elastic, expanding the cavity, that it will accommodate more and more urine, and the blood pressure inside the bladder will be near to zero, as I mentioned. This needs, as we told before, coordination between somatic also and autonomic nervous system. The normal emptying of the bladder starts with contracting of this trusor muscle, relaxing of the internal sphincter, which is involuntary, then relaxing of the striated external sphincter, which is coming voluntarily. Whenever you have the suitable time and the place for passing urine, voluntarily you can relax this striated sphincter and start to empty your bladder. The internal sphincter, which is involuntary, actually this is maintaining your continent in all over the time, minute to minute, 24 hours per day, because it will be closed. This voluntary sphincter actually will function whenever there will be will function actively when in special conditions like sudden increasing in the intra-abdominal pressure, coughing, sneezing, or sudden movement. This will switch quickly. The internal sphincter is weaker than the external sphincter. Straight external sphincter is more stronger, but less efficient. To understand this lecture, just I will give you overview about the mechanism of storage and voiding, the coordination between somatic and autonomic nervous system, sympathetic and parasympathetic. If we'll start with the bladder itself, the stretch receptors inside the bladder, whenever there will be urine inside the bladder, it will give impulses by afferent nerve to the S2, 3, 4 sacral nerves. There will be some impulses also will go to the sympathetic center in the T12, L1, L2. Usually the voiding is, think it as a reflex. يعني when stretch receptors will stretch, the impulses will go to S2, 3, 4, and the response will come through the efferent parasympathetic fibers to the bladder to contract, and by that the person will lose his control and he will pass urine. This is exactly what's happening in childhood before the age of 2, let's say. It is reflex. Stretch receptors S2, 3, 4, the parasympathetic will send impulses for the bladder to contract, and because this coordination will be not well developed, and not the cortex will not develop yet properly, the child will lose his ability or control of urine. What's happening here? This reflex, there is inhibitory effect over this reflex over the parasympathetic. How it will happen? As I told you, stretch receptors S2, 3, 4 also will send through the afferent impulses to T12, L1, L2, the sympathetic center, lower thoracic, in the lower thoracic or upper lumbar spinal cord. Immediately will through the hypogastric nerve, the sympathetic will send efferent inhibition effect or inhibition impulses over the detrusor muscles, that it will make it relax. That meaning it will inhibit the effect of parasympathetic over the bladder, of parasympathetic nerves, and in the same time it will contract the internal sphincter. By that there will be inhibition of this process, that all the sensations will disappear and the person will postpone the voiding. This is the normal process. In the same time, there will be through the pudendal nerve, impulses will go to the external urethral sphincter, also to keep it contracted to maintain the full continence. All these mechanisms under the control of, as we told, pontine storage pontine storage center, which will coordinate all these issues. And this pontine also will be under the control of the higher levels, the cortex. Any disturbance, any pathology in this neurologic system will disturb this, will affect this circle or mechanism, and it will cause voiding dysfunction or neurogenic bladder. I talk about these. The detrusor is innervating by the pelvic nerve, which is aroused parasympathetic S2, 3, 4. The sympathetic coming from T12, L1, L2, which is through the hypogastric. Also, I let you know that. Pudendal nerve, the somatic, another slide showing same meanings: sympathetic, somatic, and parasympathetic. But now I believe you understood how it's happening the problem, or neurogenic problem, neurogenic bladder. Like in other, as I keep saying to you, in all subspecialties in medicine, you will start the history, physical examination, lab investigation, and imaging. Here we have plus minus urodynamic study. I also will give you very brief information about the urodynamics. History, you will start your history from very early, from childhood, that the enuresis, infections, surgeries, calculus stone disease. In male patients, sexual and bowel history is very important, because also the innervation will come from S2, 3, 4, as you know. Drug history is very important. Like, for example, a patient is taking antimuscarinic, antispasmodics, sympathomimetics. These patients can come to you with retention of urine. Voiding history, as I told you, the LUTS, lower urinary tract symptoms, it is very important. The obstructed and irritative symptoms, you need to take detailed history about these symptoms: frequency, urgency, turia, weak stream, and the other symptoms. Physical examination, you will do generalized physical examination, systemic physical examination, but you will focus on some neurologic examinations, like sacral sensation and sacral reflexes. Perineal sensations also you need to measure or to examine. In males, the perianal area, penile scrotal area, and in females, labial or perianal skin also can be used. Anal tone, is it important? Yes. By doing digital rectal examination, we can appreciate or feel the anal tone. And the lax anal sphincter can be appreciated also by doing digital anal digital rectal examination. And if it is lax, it will reflect the denervation of the perineal floor. The bulbocavernosus reflex is also very important, because it is one of the earliest to retain after spinal shock. It is reflecting the polysynaptic reflexes, useful in testing spinal shock and reflecting the spinal cord patency. How we are doing this? By squeezing the penis and observing the contraction which will happen in the anus. I will not repeat the things which I spoke about: parasympathetic, somatic, and sympathetic nervous system. The cerebral, as I told you again, the cerebral cortex inhibits the pontine micturition center, which this center is responsible about coordination between the bladder and the sphincters. Then briefly, cerebral cortex, pontine micturition center, sympathetic, parasympathetic, and somatic. These complicated issues. Now if we'll go with the details of dysfunctions or voiding dysfunctions, we classify this into different levels actually. Usually after explaining all the previous issues, I let my students to answer these or to expect what kind of changes will happen whenever the level of disturbance or pathology will be in the neurologic system. For example, if one patient, I will skip these, let's see this photo. If one patient will come with CVA, intracerebral lesion or tumor, what your expectations about the pathology which will happen in the bladder? Yes, you answered the question properly. The coordination or the control effect from the cortex will be lost over the pontine micturition center. That meaning, if we'll go back to the previous slide, there will be detrusor overactivity or detrusor hyperreflexia, because the patient lost the inhibitory effect of the reflex down. The bladder will work separately, alone, and the patient will get continuous detrusor overactivity, contractions. What else will be affected? The coordination between the sphincter and the contractions of the detrusor muscle. That meaning this patient can have DSD, detrusor sphincteric dyssynergia. Okay. Pipe. If we'll go down, C1, L2, I will skip this to show the slide here. Sorry for here. High suprasacral spinal lesions again will cause the same problem. The coordination be lost and the inhibitory effect of the upper system will be lost. That meaning the bladder will work separately and it will cause detrusor overactivity. And what you will expect, the dysfunction in the bladder in this case, detrusor again, sphincteric dyssynergia, the coordination will be lost mostly, as I told in the previous pathology, and this patient will have detrusor overactivity again. Here we have very serious problem. Please, I need all of you to keep in your minds, because whenever you will work, maybe you will face some patients with spinal cord injuries T6 and above. T6 and above spinal cord injured patient, I mean. This characterized was severe or very high shooting up of the blood pressure. It can reach 250 over 200 or 280 over 200, bradycardia and sweating. Why it is happening? As I told, T6 and above injured patient, but if the lower distal cord is viable, which I mean the sympathetic ganglia in thoracolumbar area, this area will be affected. To make it brief in this slide, any stimulation below the level of injury, like distended bowel, bladder, any stimulation, sometimes when you are inserting catheter, impacted fecal material, or during urologic procedures for these patients, there will be afferent stimulation which will go to the sympathetic ganglia in the T12, L1, L2. This sympathetic ganglia will do massive response that it will cause vasoconstriction, and immediately after doing or happening of the vasoconstriction, there will be shooting of the blood pressure, hypertension, which will affect the baroreceptors, that it will send impulses to the brain, and from the brain through the cranial 10th nerve it will cause bradycardia. Why it is serious, as I told you just right now, because this very high blood pressure can cause cerebrovascular accidents for these patients, and instead of being in one problem, this patient can lose his life. This is the causes that can cause autonomic dysreflexia. This is also sometimes if we are doing procedures under general anesthesia, we prefer to do spinal anesthesia other than general anesthesia to deal with like these patients. Type, if lesions lower than this, it is in the sacral area, what will happen? Please, one of you can answer this question. The contraction, the parasympathetic effect over the bladder will be lost. That meaning this will be underactive bladder, a contractile bladder, a tonic bladder, flaccid bladder. Okay, and the sensations also, bladder sensation will be affected. Bladder will be like a sac that there is no sensation, no contraction, and this patient will be unable to expel the urine outside, to void. In sugar disease or diabetes, the mellitus, it will cause peripheral neuropathy, that most of these patients, or 25 of patients, will have areflexia, bladder dysreflexia. Most of these patients, will have bladder dysreflexia or underactive bladder, but some of them maybe will have trousers overactivity again. The sensations also will be affected. I feel you understand now all levels of injuries or problems or pathologies in the neurologic system, that how it will affect the voiding or storage and voiding mechanisms. If we come to the treatment, we have different goals from the treatments, but here written 3 ABC, but in my boxes your target is, the main targets is 2 targets actually. First one, to preserve renal function. As I told you, the bladder is elastic, and all the time the pressure inside the bladder is near to 0, and it will not be very high during voiding, during contraction. If being higher, the pressure inside the bladder, it will reflux urine to the kidneys and it will destroy the kidneys. Then the first important target is to preserve renal function. The second one, quality of life. These patients with, as I mentioned, either unable to evacuate his bladder or overactive bladder, has DSD, being incontinence, these patients needs to improve their quality of life, and this is very important like these cases. إذن قلنا preserve renal function and maintain very good quality of life for these patients. The underlying disease is very important. Usually when we are dealing with these patients, we'll look for the underlying disease, because sometimes some patients can come with voiding symptoms other than neurologic symptoms. Some patients, yes, can come with this. We need to take, as I mentioned before, detailed neurologic history and examination, and if we feel there is underneath, usually we'll find it, a neurologic problem, you will send it to neurologist or neurosurgeon to deal with the underlying or the primary disease, that it will, if treated properly, it will affect the voiding dysfunction positively. If we'll go one by one, we talk a lot about trousers overactivity. Trousers overactivity, how we can deal with the trousers overactivity. First of all, you will give some instructions for the patients. If it is the trousers overactivity not in neurogenic in origin, just you will give some instructions for the patients to not drink any irritative foods or drinks for the bladder, like spicy, salty foods, the drinks which contains citrate like lemon juice, orange juice, caffeinated drinks like Coca-Cola, Pepsi, coffee, and this is very important. But here usually not functioning, because this is the overactive bladder is due to neurogenic problem. First of all, we'll start with the simpler or the simplest pharmacologic therapy. We know the parasympathetic will stimulate the bladder through the muscarinic receptors, cholinergic receptors. For this reason, we are giving antimuscarinic agent, but we have long list of drugs in this family, but usually there is some side effects for these drugs, which all of you know: dry mouth, blurred vision, constipations. We have here exobutanine, we have different kind of anticholinergics, but oxybutynin is the most used drug in the tetracycline in adults, oxybutynin in children. Tricyclic antidepressants also can be used because it is doing anticholinergic and sympathomimetic action in the bladder, like imipramine 25 milligrams. It is used commonly in the nocturnal enuresis. This is maybe all of you saw this drug. Electric stimulations, usually it is not used commonly in these days. We have, before augmentation cystoplasty, we have Botox injection. If the anticholinergics will not function, or the patient will not compensate the side effects of this anticholinergics, we are using botulinum toxin type A to inject to paralyze the detrusor muscle. It is widely used in different subspecialties in surgery or medicine. This drug, we are doing cystoscopy, diluting this botulinum toxins, and we will inject. Usually, we are injecting these toxins inside the bladder randomly. This will do paralyzation of the detrusor muscle and will inhibit the detrusor overactivity. It is very effective in the cases of neurogenic bladder. The other benefit of this drug is the side effects of the anticholinergics will not be there. In Europe, there is a lot of friends which used to tell me that in Europe the patients usually prefer botulinum toxin injection, Botox injection. They are preferring this to other than using anticholinergics, which is usually causing side effects, as I mentioned. Some patients the anticholinergics can fail to suppress his symptoms or treat his symptoms. If drug failed, and botulinum toxin injection also failed, there is one third level is neuromodulation. This is small battery is usually we're implanting this battery under the skin, and the wires will be put under subcutaneous under the skin, and the wire will be inserted to the S3 sacral 3 into the foramen there, vertebral foramen. This battery will give very low voltage of electricity there, that it will affect the action potential of the nerve system in that area, and it will inhibit the contractions of the bladder. It is very effective, but it is very expensive. It is very expensive machine or modality of treatment. In some countries, more than $10,000 its cost. If it is failed, also we have augmentation cystoplasty. How we are doing? We are detubularizing the one piece of the ileum, and we are opening the bladder longitudinally, and we are stitching this part of the ileum to the defect or to the bladder edges. This can cause also decreasing in the contractions or loss of the overactivity, but these patients usually will need self-catheterization, clean intermittent catheterization, because the bladder most of the time will lose the whole ability to contract. Supravesical urine diversion, actually it is not commonly used in these days. We have different kind of diversions, but it is not commonly used. The trouser underactivity, how we are treating the trouser underactivity, to return the ability for the trouser muscle to contract. Actually it is very, very difficult. For this reason, we don't have in the market very effective drugs to treat this pathology. Before, they used to bethanyl chloride for this action or this purpose, but all the effect of it is not so promising. Underactive bladder, the gold standard way to treat this patient or to manage this patient to improve their quality of life is intermittent catheterization, a clean intermittent catheterization. Usually we are teaching these patients, if they has good hand dexterity, to do this for themselves, to use Nelaton catheter suitable size to drain the bladder every 4 to 5 hours, 4 to 5 times per day, and one time used catheter. They are setting the catheter. The idea in this one, the part of the catheter which will insert inside the bladder through the urethra, not to be touched to any to the hands or to any place in the bathroom, for example. You will keep it without touching anything, the part only which go inside. It is very effective, less infection rate, urinary tract infection rate. Usually patients will live without any catheters, foreign body inside his body. Very important for the people which they are active, because they will not be with a catheter. They will not be with catheters, especially if they are sexually active. The thing which I need you to know, not every person with neurologic disease will be bedridden or chair bound, or no. We have a lot of friends around us in the hospitals, the hospital staff, doctors, nurses. They has underactive bladder and they are unable to expel their urine out, and they are keeping these Nelaton catheters in their pockets or in their bags, and whenever every 4 hours or 5 hours they are going to bathroom, inserting the catheter and evacuating the urine. If the patient doesn't able to do this with himself, the caregivers can be learn and or can be taught, and they can do it for their patients. Credit maneuver. Some paraplegic patients can do credit maneuver to expel the urine out by making some pressure to the lower abdomen. If there is DSD, detrusor sphincteric dyssynergia, this also can cause problem for the upper system, because the bladder will contract, as we mentioned before. The bladder will contract, there will be relaxation of this external sphincter and the internal sphincter before that. But if this patient has DSD, detrusor sphincteric dyssynergia, the bladder will contract and the sphincters will not relax. This will cause high pressure in the bladder. And I need you to know the intravesical pressure. If it is more than 40 centimeter water, 40, for sure it is very dangerous for the upper system. The urine will be refluxed up and it will destroy and making deterioration for the kidneys. In some cases, if there is overactivity or DSD, we can put patient on anticholinergics drugs and teach him how to do intermittent catheterization. DSD, detrusor sphincteric dyssynergia, generally the pharmacological treatment is unsuccessful. There is some drugs, baclofen, dantrolone, diazepam can be used, but most of the time it is not effective. Sometimes we can put a stent and make the patient incontinent on the appearance or in the here. External sphincterotomy, also we can do this. We can cut the external sphincter by doing endoscopy and doing complete cut or resection of the external sphincter and make the patient incontinence on external applicator. We can put external applicator to connect it with a bag to collect the urine. Botulinum toxin, injecting botulinum toxin in the external sphincter also can function by paralyzing the external sphincter and keep the patient his sphincter relaxed. If the urethral is incompetent, the urethra, due to neurologic problem, also it can be used in the same manner. We can do, if there is pseudoephedrine, to maintain the contraction of the internal sphincters, but usually we are not using this commonly for these purposes. Sling procedures in some incontinent patients, completely incontinent patients, because of the non-functioning internal external sphincter altogether. Usually we are using slings. This is like a tape we are inserting under the bladder neck in females and under the bulbar urethra in males, that it can affect the it can maintain the continence of these patients. If we'll talk here about the incontinence or in females, as I discussed with you in one lecture, in females the continent mechanism depending on the pelvic floor muscle strongly, because female has, like male, intrinsic sphincter but weaker than which in the male, and the striated sphincter will be in the middle third of the urethra, and also will be weaker than in male. For this reason, females also depending on pelvic floor muscle on the continent. The pelvic floor muscle will be like hammock effect over the urethra. Hammock effect over the urethra. It will support the urethra from down. That the females, whenever they will cough, sneeze, or any intra-abdominal pressure will be there, the urethra will be fixed on the fixed underneath it, fixed plate or pelvic floor muscle, or that it will coaptate. When it will whenever she will cough, this urethra will be coaptated, closed. By advancing in the age or after multiparities, this effect of pelvic floor muscle will be lost. The pelvic floor muscle will be loose. That this urethra which will be fixed over the fixed base, let's say, will be mobile, and this is the pathology usually of the incontinence after multiparities in females and after multiparity in females, which we call the urethral hypermobility. That the patient or the person or the female, the lady, will cough and the urethra will be mobile, that it will not be coaptated, fixed like hammock effect will be lost, and the female will lose her ability to control the urine. The urine will be leaked out. The other cause of stress urine incontinence in female, other than the urethral hypermobility, is the intrinsic sphincter deficiency, which is because of advancement in the age and some patients with long-standing diabetes mellitus. Also, this group will have stress incontinence due to this two pathology, mainly in females. Neurogenic, also patient with neurologic disease can have urinary incontinence. Sling is very important to treat this pathology. In neurologic patient, we can put a sling, and we can teach the patient how to do clean intermittent catheterization. He will be continent, and he will evacuate the bladder by putting an electron catheter. In females without neurologic, which they don't have neurologic problem, and which they has stress urine incontinence due to multiparity, we can put, as I told, a sling, trans-obturator tape insertion, or tension-free vaginal tape insertion. This is very thin, around 1 centimeter in dimension tape. We are inserting with the quick procedure, blind procedure, doing small incision under the urethral meatus, and we are inserting this tape under the urethra, under the mid-third of the urethra. This will be kept there, as I told, tension-free, will keep there like in a hernia. This is mesh, non-absorbable mesh. This tape, very fine. After 1 month or 6 weeks, there will be fibrous around this sling. Okay, and this will fix the urethra, that the patient, when she will cough or sneeze or do movement, this will do the hammock effect again for like these patients. Okay, if the patient, as we told, have neurologic problem and unable to control because of he lost or she lost the continent mechanism down, just we can put like this tape, and we can teach them how to do clean intermittent catheterization. We have three kinds of incontinence, mainly the main three kinds of incontinence. We have urgent incontinence, which urgency preceded, or urgent incontinence which is preceded by urgency. And this is common used either because of neurological problems. It will be neurologic urgent incontinence, or can be idiopathic. We don't know why, and it is common in females than males. Commoner. This patients can be treated, as we mentioned in the urgent incontinence before 3-4 minutes, by instructing them, as I told you, to be far away from the irritative drinks and foods that can irritate the bladder. As I told you, if felt, it's just you can put them on pharmacologic treatment like anticholinergics, cyclic antidepressants. If failed, also you can inject low dose Botox or botulinum A type A toxin. If failed, again we can put them on neuromodulation. It is very effective. Interesting. This is the urgent incontinence. Stress incontinence, I told you, we can treat it in females usually with stress incontinence by instruct them to do Kegel exercise, pelvic floor muscle exercise, to strengthen the pelvic floor muscle and returning it to do its effect, hammock effect under the urethra. If failed, just will put them on the sling. We have some patients with mixed urinary incontinence, urgent incontinence, and with stress incontinence, and these patients just we treat with urgent incontinence first, that it can, and put them on pelvic floor muscle exercise. Sometimes they will see a lot of benefits, especially not very old people. The young ladies can have response or good response for this modality of the treatment. We have another types of incontinence. We have overflow incontinence. I mentioned to you before in another lecture that in some patients with infravesical obstruction, like a patient with enlarged prostate, for example, or underactive bladder, they can get overflow incontinence, like a cup. As I told you, we are filling it with fluids or water. After being full, it will the most or the extra amounts of fluids will flow out. This is very important, and these patients usually you will treat the primary problem if they has prostate problem, or if they has underactive bladder, you will put them on clean intermittent catheterization. We have functional incontinence. Functional incontinence, which is patient not aware about. In the patient, this can be found in the patients with dementia, usually in old people, old patients, which they are not aware, like with children again being, they are not aware about that they have a sensation of voiding and you need to go to bathroom to evacuate. For this reason, these patients usually we are instructing the families to keep reminding them to go to bathroom every 2 hours or 3 hours. Please, can I take you to bathroom? This is exactly what they will do with like these patients. In incontinent patients also, especially in male, and we can use it in female, we have artificial urinary sphincter. Artificial urinary sphincter is also a system with a cuff will be around the bulbar urethra, balloon regulating or pressure regulating balloon will be inserted in retropubic area, and the pump will be in the scrotum in male and in the labia majora in female. By pressing this pump, usually this cuff around the bulbar urethra and around the around the urethra near to the bladder neck in females will be closed. This cuff full of water. Whenever these patients will they want to pass urine, thus just they will press the pump in the scrotum or in the labia, that these fluids will go back to the pressure regulating balloon in the retropubic area, that it will the pressure effect of this cuff will disappear for a minute, 1 minute only, that the patient can void. Then it will refill spontaneously again. If the patient or the person continued or emptied his bladder or her bladder totally, this will be enough. If they feel that there is some residual, they will press again to the pump, open the cuff again, and continue or complete their urination. And this is very effective but very expensive. Actually, it is around more than $10,000 also, this machine. There is some bulking, non-absorbable bulking agents that can be injected around the urethra, like if you remember deflux injection in vesico-urethral reflexes in pediatrics. It is bulking agent, non-absorbable, that can be injected around the urethra, but this kind of modality of treatment can function in mild urinary incontinence other than severe ones. Autonomic dysreflexia, your action in like these cases, as I told you, maybe you will face this problem anywhere in medicine, in emergency department, in medical department, medicine department, in everywhere with patient with T6 and above. As I told you, you need to know how to deal with like these patients. First of all, you remove the precipitating cause. If the bladder is over distended, or the subarachnoid, for example, patient with subarachnoid catheter, maybe it is blocked, you will immediately put a catheter, change the subarachnoid, do anything to evacuate the bladder. And the next step will be give any hypertensive drugs like nifedipine under the tongue, vastly effective, and you will let the patient, if he is in supine position, to sit him down or put him in sitting position or semi-sitting position, and usually you can save his life. The most important thing in the autonomic dysreflexia, if you are doing any procedure for like these patients, you need to expect this. Prepare yourself that maybe this patient can get autonomic dysreflexia in any time, and you will prepare yourself how to deal with this patients. Usually, for example, in our urodynamics suite in Shifa Hospital and everywhere in the world, all over the world, we have e-card, including all drugs, or there is all drugs, emergency drugs that can be used. There is a monitor to monitor the blood pressure during doing this procedure. I will finish my lecture by giving to you case presentation. This is a 3 hours baby girl born with lumbosacral myelomenincocele. This is pediatric patient. The urologist consulted. Mother has a history of inadequate prenatal care. She doesn't take folic acid during pregnancy. Physical examination, the baby was well with this meningomyelocele. bladder was palpable. They instruct the mother to do clean intermittent catheterization (CIC) and ultrasound requested, and the meningeal closed by the neurosurgeon within the first 24 hours. This is the initial ultrasound. Maybe you can't feel. There is very mild hydrocalysis here in this ultrasound. Discharge home, and the mother, as I told you, instructed to do clean intermittent catheterization every 3 hours. In 2 months, in follow-up, MCUG or VCUG, this was the MCUG film. As you see, the bladder is with normal regular outlines, no refluxes, everything going perfect. The patient lost hair follow-up for 9 months, and as we knew later on that the mother was not doing CIC, clean intermittent catheterization. This patient came to the hospital with urosepsis. Bladder fully catheter inserted and antibiotics given. Ultrasound done, and you can see the hydronephrosis became more and more, as you can see here. Ureter dilated excessively. MCUG showed this shape. This is grade 5 vesicular reflux, as you see, tortuous ureter. It is ugly photo actually. Urodynamics done in this moment. Leak point pressure was 60 centimeter. It is higher than the 40 which I just told you. Because of that, the upper system affected, because high pressure inside the bladder. Capacity was 110, but because because of the pop of effect on the ureters, that some of this fluids inside or urine inside the bladder will be refluxed up. For this 110 ml of the capacity is not accurate because of this amount of urine which being in the ureters. And there was, as you see here, frequent uninhibited detrusor contractions, detrusor overactivities. This patient, they put him on anticholinergic drugs, oxybutynin, with the clean intermittent catheterization again. But sadly, because I believe the family doesn't giving good care for this child, this girl came back with urosepsis. In that time, the decision taken to do vesicostomy with the urinary bag to put, or in the pampers, put the pampers initially to decrease the pressure inside the bladder, and the child continued on follow-up. This is also I need you to know, we are doing, maybe I mentioned before, to do urine flowmetry. This is an example for urine flowmetry. Bell shape, this is the normal. The top here in maximum flow rate, usually it is age related. In young age group it will be the maximum flow rate very high, 20s to 30s. In females sometimes more than 30, because as we told, the continent mechanism is less than that in male. They are super voiders other than the males. In patient with age around 50, 60, the maximum flow rate, if it is 15, we can accept this as normal also. Okay. This is an example for urodynamic study. This is a suite, urodynamic suite, that it is depending on the elevation of the fluids in the tiny tubules, like you learned in physics. So for this reason we are measuring the pressure here by centimeter water. There is a pump. Usually we are doing this briefly because I am finishing this lecture. We are inserting something we call cystometric catheter. There is 2 lumens inside this catheter. One of these lumens will be connected to a pump that will fill the bladder gradually in a rate which we are putting in the software. And the other lumen, which inside this cystometric catheter, which is being the tip in the bladder, will be connected to a manometer to measure the intravesical pressure. The other, we have another rectal catheter. We are inserting usually through the anus to the rectum, and it will be connected to another manometer, which will measure the intra-abdominal pressure. Here we have all these will be connected to a software on a computer system, and this will have, here will have like you see here, traces. Here, as you can see, the green one vesical pressure, and the blue one is abdominal pressure. Here there is third pressure, is the trousseau pressure. Can we measure that trousseau pressure? No, directly we can't measure it. But if you imagine that the pressure inside the vesica, the bladder vesical pressure, is a sum of 2 pressures, the trousseau pressure and the trousseau pressure and the abdominal pressure. That meaning by doing we can get the trousseau pressure. Yani P vesical is equal B abdomen and P the trousseau. The trousseau will equal P vesical pressure minus abdominal pressure. And here, as you can see, we have 3 traces. We have another trace, is the flow rate. Here there is 2. We are usually simulating the natural way to storage and voiding pattern. Usually we are infusing this fluids slowly to the bladder and monitoring the pressure, the effect of the pressure. Here we can get if there is severe or high pressure in the system, more than 40, for example, in some cases of neurogenic bladders. Very important modality for diagnosing the neurologic patients, because not all the time neurogenic or neurologic patient can express his symptoms, and most of the time they don't have the sensation to tell you that they have this or that. And most of the time, to follow these patients, to have baseline information about their condition, bladder pressures, you need to do urodynamics, and you can follow them later on, especially if the patient has progressive neurologic problem, that maybe it will be worse and worse, or if he is under treatment, that his disease maybe become more good. Storage phase, while we are filling this the bladder with saline, we are monitoring the pressures. We are looking for, in the storage phase, for the sensations. If patient has or able to feel sensations, first sensation, first desire to void, and strong sensation to void, desire to void. We can get from here the maximum capacity of the bladder. We have the compliance. We will see if the compliance is normal or low. compliance reflecting the elasticity of the bladder. As I told you before, the bladder, the trousers muscle is elastic, that it usually it will dilate whenever it will be more relaxed whenever there is more volume of urine inside the bladder. But if there is any problem, neurological problem in this bladder, this will not expand. That meaning the compliance will be low. The compliance will be low. As we can find it here, like steadily increment in the pressure. We can do Valsalva maneuvers here to measure or to diagnose urodynamics, stress incontinence, by observing leakage of urine, increasing. Let the patient to do Valsalva and to do Valsalva and do strong 3 cuffs, and see in that condition situation you will find the abdominal pressure will be very high here, and you will monitor the urethra if there is a leak. This is the storage phase. After being full, the patient, you will instruct him to void without using abdominal wall muscle, without straining. And in voiding phase, after stopping the pump and giving the patient a chance to void in a very quiet environment, you will observe the trouser movement here, the trouser pressure, if it is moving or silent. In the cases of underactive bladder, you will find no movement in the trouser muscle. The trouser muscle will be silent, no increment in the pressure, it will be very low. And if there is any movement in the trouser pressure, you will see if it is high, very high, with low flow. This is the flow rate, as I mentioned, flow meter here. If low flow, high pressure, that meaning the bladder is doing a lot of efforts to expel the urine out. This can be found in the cases of obstruction. In some cases, in underactive bladder, you will find flaccid, like there is no movement in the. If patient will void by using abdominal wall muscles or straining, you will find movement here in the abdominal pressure. In the I forgot to tell you, in storage phase also, we can see the trouser overactivities here. In the trouser, this is the trouser pressure. While we are filling the bladder, we will appreciate the trouser waves here, over increment in the waves, or waves coming up in the trouser pressure and then coming down. This pressure, if it is very high, more than 40, it is very dangerous for the upper system, sometimes being more than 100 or centimeter water, the pressure of the trouser while it is contracting as the trouser overactivity. This is very important modality for diagnosing and following this kind of patients. As I told you, usually we are infusing saline, but if we'll infuse contrast, diluted contrast, and using C-arm to take a photos during study, we call this video dynamics. We are doing static and dynamic study. Anatomical also informations we can be taken during the study, when will be the reflux in the shape of the bladder. The leak also, you can observe this leaks while doing this x-rays. This is another example, as we told you, video dynamics. Here you can see the B vesicle, as I told you, B abdominal, and B the trouser, which is by being B vesicle minus B abdomen will be the trouser pressure here. As you can see here, for example, the trouser pressure here is 27, abdominal pressure 9. The vesicle will be the sum of both. 27 plus 9 will be 36, as you can see here. We have this lab or this suite in the Shifa hospital, and myself, I am doing these studies because, as I mentioned in the initial lectures, I have fellowship in voiding dysfunction and urodynamics. Thank you.